Hello everyone, today we will be discussing systemic lupus erythematosus, in short SLE. So let's begin. Lupus is an autoimmune disorder, and when someone says autoimmune, we think of antibodies causing tissue injury. We also know that injury involves inflammation, so the basic concept you need to know for SLE is that there will be widespread inflammation throughout the body. If there is one thing you have to remember about autoimmune diseases, or in this case SLE, is that it is very common in females of childbearing age. We are talking about a 10:1 ratio in female is to male. This is very important. SLE is a type 2 and 3 hypersensitivity reaction. So as you know, in type 3, antibody antigen complexes are formed which lodge in the microcirculation and thus cause damage via complement and inflammation. Type 2 involves formation of IgM and IgG antibodies against the antigens present on the cells, for example RBCs, so they will cause destruction of these cells and result in cytopenia. There are certain HLA genes which predispose people to SLE, and there are two which are commonly seen in exams, HLA-DR2 and HLA-DR3. Again, this is high yield. Environmental factors like UV light and drugs like hydralazine, procainamide and isoniazid cause drug-induced SLE. Last of all, I want to stress upon the fact that because of widespread inflammation in the body due to these antibodies, you will see symptoms covering nearly all the organ systems, which you will see in the next slide. Coming to the clinical features, remember that the underlying pathology is inflammation. So all the clinical signs and symptoms you will see will be explained by inflammation. Wherever inflammation is present, fever will be there, as you know from pathology. You will also see dermatological manifestations in the form of malar rash, photosensitivity, oral ulcers, and as you can see from the image, skin symptoms are seen in more than 70% of cases. So this is important. Then inflammation in the musculoskeletal system will present as muscle pain. In the joints, it will present as arthritis, which is seen in 90% of cases, by the way. In the kidney, it will present as lupus nephritis. Lupus nephritis can either be a nephritic syndrome or a nephrotic syndrome. More commonly, you will see a diffuse proliferative glomerulonephritis. Renal damage is the most common cause of death, so this is high yield. Inflammation in the heart will give rise to myocarditis, pericarditis or Liebman-Sachs endocarditis. Liebman-Sachs endocarditis is a special kind of endocarditis, and this is how. Normally in endocarditis, you see vegetations in the mitral valve, but they are only present on one side of the valve, either above or below. However, in Liebman-Sachs endocarditis, you will see vegetations on both sides of the valve. Liebman-Sachs is also high yield. As we discussed earlier, lupus is a type 2 hypersensitivity reaction, and IgG and IgM antibodies attack the WBCs, RBCs and platelets, that is all the cells which have cell surface antigens. This will give rise to leukopenia, anemia and thrombocytopenia. As a result of loss of these cells, the immune system is weak and thus opportunistic infections are seen. Infections are also a common cause of death in SLE patients. Inflammation in the CNS will cause CNS psychosis, while in the lungs you will see effusions, pneumonitis, etc. As you can see, there are a lot of symptoms in SLE. There is no need, however, to learn these by heart. All you need to remember is that inflammation in these organ systems will present with relevant symptoms. We use anti-nuclear antibodies for screening SLE. It is sensitive but not very specific. If the ANA is positive, we further search for anti-dsDNA antibodies, which is a very specific test. Anti-Smith antibodies is also as specific. I had mentioned earlier that drugs like isoniazid, procainamide and hydralazine cause drug-induced SLE, which in that case, you will have to search for anti-histone antibodies, again high yield. SLE is associated with Anti-Phospholipid Syndrome. What is Anti-Phospholipid Syndrome? Antibodies are formed against proteins bound to phospholipids. Now that you know this, it will be easy to remember that SLE, an autoimmune disorder, is associated with Anti-Phospholipid Syndrome. You need to know two antibodies which are formed. One is anti-cardiolipin and the other is lupus anticoagulant. Anti-cardiolipin antibody is also seen in syphilis. So this antibody can give a false positive syphilis test. Lupus anticoagulant antibodies attack the anticoagulants, so as a result, there is an increased risk of coagulation. This increases the risk of complications like deep vein thrombosis, stroke, etc. So because of this, we have to give the patient lifelong anticoagulating therapy to prevent these complications. Last, we have treatment. Remember that the cause behind all the signs and symptoms is inflammation. So for acute attacks, we will give anti-inflammatory drugs like glucocorticoids. Hydroxychloroquine is given in the long term to prevent acute attacks and reduce the mortality. For acute cases, again, we have glucocorticoids, but if that is not sufficient, like in severe cases, we can additionally give immunosuppressive drugs like mycophenolate and azathioprine. This brings us to the end of this video. See you in the next one.